And now, let's begin with our program. If you are just joining us, we welcome you to Mind Matters, the community mental health education event for NAMI Central Texas. Our event today is generously sponsored by Ascension Seton, and we are so grateful for their support. Again, my name is Dr. Rebecca Farrell, and I am the Program and Outreach Director for NAMI Central Texas. I'm so excited to be here tonight to help moderate an information conversation with Dr. Lowell McRoberts of Ascension Seton to talk about secondary or vicarious trauma. Our format today is going to be a little different than what you might be used to in webinar settings. We want to really focus on the big questions around this topic, and so our conversation will be centered on some of the big questions we have, and then continue with questions from our audience. Good evening and welcome, Dr. McRoberts. Please tell us a little about yourself and your work.
Thank you, Dr. Farrell. I'm happy to. If you'll leave that slide up for 1 second, I think it's important to know, but I was kind of thinking about this and rehearsing it. My wife saw me doing it and saw that picture, which is about 2 or 3 years old and pre-COVID. And what she said to me explicitly was, I need to know that you don't look like that anymore. You get that, right? And I'm like, all right, I get it. Like a little bit less hair, a little bit more gray on the beard. I totally understand. But she was really emphatic, but I understand that. I think Dr. Farrell did a fantastic job at teeing this up, and I'm really excited to answer the questions that people had about indirect stress and secondary trauma. I think it's helpful, and I hate talking about myself, but the only reason I want to bring this up is that I think it's useful as we start this conversation for me to give you some sense of the kind of who I am, why I'm here, what I do, and the lens that I'm seeing things through in terms of where I've grown up and what I've done. And I think that's really helpful for everyone in this conversation to have that understanding. So if there's issues or concerns or other thoughts that relate to what we're talking about, you know where I'm coming from and you know why I may or may not have those things and how I can be sometimes blinded to some of the experiences people have, but also have some experiences others may not, which helps me make this conversation. Born and raised in Lubbock, Texas, went through all my schooling there, ended up going to college in Austin College, which is just north of Dallas, did my medical school in Galveston. And then after finished medical school in Galveston, decided I wanted to be a psychiatrist, ended up in Brown at Rhode Island. And I was at Rhode Island from 2000 to 2007. And as we talk about later in this kind of discussion about indirect stress and secondary stress, I think the thing I would kind of reiterate is that I was there, not in New York, not anywhere close to it, but was present during the 9/11 attacks. And so was there for that. Since 2007, I've been back here in Austin, ended up marrying a public school teacher who was a vegetarian marathon runner, and we wanted to come back to Texas because my parents had retired and moved to Kerrville. And so in terms of towns in Texas that we could live in for a vegetarian marathon running public school teacher, Austin was kind of our primary place we wanted to be. So we're here because of that. And I've been here ever since. My job since I got here in 2007 has been kind of fourfold. And I'll tell you where I am right now. My current kind of thing that I do is my day job, and what I really enjoy the most is being what they call a consult liaison psychiatrist. And what a CL psychiatrist means is that I spend my time in the kind of major medical surgical facilities. So here in Austin, that's Del Seton Medical Center, it's Seton Medical Center Austin, it's Hayes and Williamson. And so what I typically do is manage patients who are in those facilities who are having either psychiatric issues or who are there secondary to their psychiatric issues. So somebody who's come in with problems, they've got a psychiatric issue at baseline, and so they're there in the hospital and so need our help. Somebody who's there in the hospital who's developed psychiatric issues and then needs care after that. And so my kind of day job is that I spend as much time as I can in the kind of major medical surgical facilities here in Austin. The second big thing that I do is that I'm part of the training program here. So I'm the training director for the psychiatry residency program. And so every year we have medical students who apply to come to Austin to be psychiatrists. And so you graduate from medical school, you want to come here to be training, and part of the training we have is something that's kind of what Austin does and how awesome Austin is and the kind of things we can offer. So as an example, we had 1,400 people apply to become one of our 8 residents here in Austin. And then those people will in 4 years graduate and be the psychiatrists that you're seeing or working with in the community who help shape what happens with NAMI, what happens with all the stuff that goes forward from there. So that's kind of my other major day job, is helping to run that residency program. I'm also part of Dell Medical School, which has been something that was been a really complicated partnership that we've created with Ascension, but something that I'm really excited about, and something that's a really strong connection with the community and a really strong sense of how we talk about what we're doing academically, is what we're doing in terms of research. And a lot of what I'm going to talk about next is going to be involving some of that research and data. And then lastly, I run the group that does a lot of work with psychiatrists. And so for outpatient, inpatient, trauma, consult, all those different kind of psychiatrists, I've had a really close exposure to. And so I say all of that just to say that's where I'm coming from with this talk. And just as Dr. Farrell said, if there's kind of triggering our thoughts or anything else, I just want to make sure that it's very overt. That's the lens that I present this in, as someone who is part of an academic medicine group, who is part of a residency program, who has been here since 2007, and who is very heavily involved in kind of how the hospitals run and how the physicians here in the hospitals work. And Dr. Farrell, I'm going to go off topic for a second, but the other thing I wanted to say is that we had a lot of stuff going on, and then I was not, I'll say this, when I heard the talk was for NAMI, I was like, all right, we got to manage that. And so I say that from a couple of different things. I would say that working here in a hospital system, so I work for the Ascension Hospital System, so that's Seton Shoal Creek, it's Del Seton Medical Center, it's SMCA. NAMI has been a massive resource for us and one of our most valued resources in terms of trying to make sure that people and families who have concerns about psychiatric issues are able to get care, help, understanding. And so I've, in the 15, 14 years that I've been here, I've never been a time in which I haven't felt that NAMI's been a fierce advocate for my patients. And so I'm really eager to be a fierce advocate for them back. I would jokingly state that institutionally, both Del Seton and Ascension have been really interested in making sure we partner with NAMI because we understand the mission. I was asking Dr. Farrell if it was okay to mention this beforehand, but my boss's boss during the NAMI walk frequently yelled at me and said, you know, Sally Hernandez is raising more money than we are. What's our problem? And so then we had to go through and kind of figure it out. But I think it's a testament to the organization that's been created here, the skills and strengths they have, and then how well it's received by a large group across the community. So again, long way of me answering that, Dr. Farrell, and I'm sorry, but I would just say that I'm thrilled to be here and really happy to engage in this conversation. And so thank you all for taking your time on a busy night to do this. And so I appreciate it and thank you.
Well, thank you, and we appreciate your support. And one thing before I begin with the first question is, as you shared about your boss's boss joking around with Sally Hernandez, I think it's important to remember that humor is important in our lives, and that we need to be able to integrate that into our lives and use humor in appropriate and healthy ways, because it does impact our mental health. And so with that being said, I would like to begin with the first question. And of course, technology. What is secondary or vicarious trauma?
And thank you, Dr. Farrell. And again, I want to make sure that any humor I use is, I think, in appropriate and kind of in conversation with that. So thank you for making sure that I'm being thoughtful and mindful of that. You know, the definition of this, and we'll talk about this in a second, I think over the course of the rest of the Q&As that I get, we talk a lot about secondary or vicarious trauma. And where we come down with that is that there's very clear symptoms and very clear disorders that are the result of people who have had to experience very difficult or disturbing images or stories or experiences from people that they're close with. And so when we talk about secondary or vicarious trauma, we're talking about, generally speaking, the stress that's involved from people helping others or commiserating with someone who's had a traumatic experience. So it doesn't mean that you've experienced those traumas directly necessarily. What it means is that you've been sitting there with someone who has experienced these traumas, and then the consequences that come from developing that. And so when I talk about secondary or vicarious traumas, that's what I mean. It doesn't mean that you've been through an awful experience yourself. It means that you love somebody who's been it. It means you've worked with people who have. It means that you've been stuck in a scenario in which you've been forced to expose yourself to all the kinds of these negative experiences that others have lived through, unfortunately. And so that's what I mean when I talk about secondary or vicarious trauma.
Thank you. And I believe too, when we moved to the Diagnostic Statistical Manual, the DSM-5, the individuals who were in charge of that recognized the importance of secondary or vicarious trauma for individuals who were taking care of their loved ones who have mental health conditions. So with that being said, what is the difference between secondary trauma, post-traumatic stress disorder, compassion fatigue, and burnout?
I think it's a fantastic question, and one that I'm laying awake at night struggling to figure out how to answer appropriately. I think the definition of trauma has been an incredibly difficult one for psychiatry and psychology to manage in general. And I'll say this, I would say that, I work with oncologists, I work with orthopedic surgeons, I work with all of these people. And the part that I am jealous about their job is that if you're an orthopedic surgeon and someone comes in complaining of arm pain, you can do an x-ray, you can see there's a broken humerus bone, and you can say, hey, this person's got a broken arm. We got to figure out how to fix that. With psychiatry, we've struggled for 1,200 years now to come up with a great way to define what psychiatric illnesses are, for lack of a better word. And we really struggle with that because there's competing elements of wanting to make sure that there's very clear things that we appreciate are causing real problems, but also fully understand that the last thing we want to do is pathologize what's normal response or try and overly engage psychiatric diagnoses for people who don't really have psychiatric conditions. And so when we don't have imaging, when we don't have lab tests, when we lack those things that really clearly define psychiatric illnesses, we really try and struggle with how to then diagnose people. But I think it's really important to make a really accurate diagnosis because all of our medications, all of our therapy treatments, everything that we do really is tied in academically to a specific diagnosis. So if someone comes in and they've got classic depression, I know which medications can be helpful or not. I know what kinds of therapy can be helpful or not. And so if we don't make that diagnosis, it's tough. And so the mechanism by which we make that diagnosis is something called the DSM. And the DSM is kind of a set of guidelines and criteria that really try to narrow down what it means for someone to have a specific diagnosis. I would love for those things to be, again, based on a blood level, based on a lumbar puncture, based on an x-ray or MRI. They're not. And so what we try and do is really clarify when we talk with the patient and go over the things that they're experiencing. How do they kind of lump together in terms of what they're having, what those symptoms are like, what their functioning is like? And that's what really helps us kind of be able to organize those things into diagnoses. And so when we talk about PTSD, compassion fatigue, burnout, secondary trauma, all those things are really difficult to really narrowly define. And so trauma has been one of those things that we've really struggled to talk about. I mean, I think everyone knows it when you see it. So if someone's had a traumatic experience, you know exactly what that is to feel that in your heart. In terms of what it means, in terms of trying to document it and then create a very clear, separate series of diagnoses is really, really difficult. The DSM-5 that Dr. Farrell brought up is kind of a diagnostic manual that we use to talk about how to really kind of clearly define what people's experiences are as best we can. And in terms of talking about trauma, PTSD is kind of the one that everyone knows and everyone thinks about. The only thing I would disagree with Dr. Farrell about slightly is that she said that we've worked hard to kind of include a lot of stuff we kind of didn't, and that's on us in psychiatry. And we made a lot of mistakes over the course of the past 100 years, but this was one of them. the initial points of trauma were very clearly things that you had personally experienced. And so it could not be anything that you had heard about, lived with, or done. So for the first kind of 4 iterations of DSM, it was really a conversation about, you had to have a life-threatening situation, you had to have a horrible assault, you had to have something awful you've witnessed or gone through, imminent symptoms because of it. And that's tough. And I think where a lot of that changed, and again, this is me jumping around a bit, but where I kind of think about from my own experiences in 9/11, I'm a shrink. I'm a psychiatrist. I was working in Rhode Island. I was working in an emergency department, and I'm doing my consult stuff. So I'm working with a med surg facility with kind of a level 1 trauma center. We're Rhode Island versus New York, so we're super far away, but we see what happens at 9/11. And it was awful for us. And I'm sure it was awful for a lot of people here in the room to kind of see those things and feel what's going on. We had docs who were working with us whose families lived in the towers, all those kinds of things. And so it was a miserable series of time there for us. And we had a lot of consequences to that. By the same token, how do those match up to someone who was in the tower when it happened? How does that match up to someone who was living 4 blocks away when it happened? How does it match to a firefighter who was living in Texas who had no real connection with it, but really identifies with the firefighters who lost their lives during that time? And so I think we're really aware in that context that trying to make a diagnosis about someone's traumatic experience is really tough because it can involve all of those things. So they all equal? No, but do they all have some real validity to them? Absolutely. Like, I don't think I would be anyone who couldn't say that. And the other kind of example I use is what the COVID mess has been. So as running a hospital, running a medical group, working heavily in the med surg centers, the past 2 years have been, 1.5 years, 2 years have been really hard. And it's been really hard in a lot of ways for my nurses, for the docs, for everyone else involved. It's just been bad. And again, I'm a psychiatrist. I'm not going to pretend what it's like to be a nurse practitioner, a nurse, a social worker, someone who's working on the trauma floors. But I know what it's like for me to work, 19 hours straight, then not get much sleep and come home and then go back. I know all of those things. And so is my experience different than theirs? Yes. Does it make it any less challenging and what it means for me? No. And so I think that's where the diagnoses have really struggled. And so we as a profession are really trying hard to catch up with that. We as a profession are trying really hard to make sure that we make those diagnoses appropriately, because I think if we can really narrow down what those diagnoses are, it helps us define what treatments work or don't work. I would say that to your question, it was a long answer to your question, Dr. Farrell, but what I would say in terms of the things that we're really focused on, I would say that when I in my mind, I'm thinking about PTSD, I'm thinking about someone who's had a very direct experience with something overtly traumatic. So threatened loss of life, threatened loss of a lot of stuff. Or I'm thinking about somebody who's been in a very direct relationship with somebody who's had those experiences, or a first responder who's been experiencing all of those kind of things that have been going on right now. When I think about compassion fatigue, I think a little bit differently. I think that's anybody from a public school teacher to a nurse to a social worker to anybody who's been involved in a really difficult scenario who is just absolutely toasted and fried and burned out. And whether it relates to trauma or not, someone who's very clearly kind of experiencing some detrimental aspects in terms of dealing with somebody else or working with somebody else who's had negative experiences. And then burnout, I think in my mind, it takes a step back from that first responder or someone who's experienced direct traumatic experience as someone who's just been ground down by this, right? And so when I think about it in my own head, I'm thinking about, compassion fatigue would be a nurse who's worked her 7th 12-hour shift in the ED in a row. I think about burnout would be somebody who's working at Taco Deli, who has been trying to run that group when 3 people have called out sick, and so they're the only person working in the kitchen, and she's been doing that for 19 hours straight, and she's getting paid $7 an hour, and she's done, and she's done in a way that it's broken her. And so I think the big thing that we as a field are struggling with is how do you divvy up those diagnoses, and what does it mean? And again, Dr. Farrell, it's a long answer to your question, but I don't think there's a great answer to it, but that's the way that I would kind of see how those things distinguish themselves and separate themselves.
Thank you so much, Dr. McRoberts. As you were talking and through my own personal experience too with these concepts, There are some similarities. In my mind, there are some similarities amongst these concepts, but then there are also differences, which you alluded to can be difficult to wean out, glean from each other. Um, and I know that we talk a lot about compassion fatigue and burnout and having that secondary trauma. And we're seeing it more now with COVID and being in our second year of COVID.
Yeah, and I'm more than happy to talk about that. But I
Yeah.
think it's been something that we've all felt. And again, it's easy for me to say, I'm a doctor, I've gone through this, but there's not a person I know who hasn't been hammered by this. And so it's not a physician thing, it's not a nurse thing, it's not a healthcare thing, it's all of us thing. And so it's been a tough time frame.
Yes. Oh, who is at risk for secondary trauma?
Um, and again, part of the diagnosis is difficult. What I would say is that anyone who's at risk for a significant secondary trauma is classically somebody who's been dealing with a population that's experiencing a lot of traumatic stuff. And so, for example, what I would say is, there's organizations here that work with minors who have been sex trafficked. And so the case managers, the social workers, the psychologists, the psychiatrists who are working in that population are at risk. I think there's police officers. I think there's firefighters. I think there's paramedics. I know there's physicians. I know there's nurses. I think people who are kind of living day to day with really traumatic experiences and then having to figure out how they manage that and process that. Now, the other thing I would say to that is that, if you talk to me pre-COVID, 10, 15 years ago when I'm younger and kind of less experienced, I'm really kind of narrowing it down to that population and feeling very comfortable with that. Nowadays, I feel really comfortable with saying with that. I don't think that's really narrowed down to first responders and physicians. And I think even though that's part of the diagnoses right now is first responders, I don't think that really holds up over the past couple of years. And I would suspect it would be a lot differently. I mean, I've got patients who are flight attendants, and I don't want to say kind of what their experience has been, but I would argue that, someone who's working on Southwest or someone who's working on an American Airlines flight, it's had a really bad couple of years. And I don't think that's got anything to do with being a first responder. It's tough. So again, the woman I know who's working on Taco Deli or at Pint House, I mean, they've got real challenges in terms of what they've gone through. And so again, I think this question was easy to answer 10 years ago, harder for me to answer now. But the thing I would really say is someone who's kind of living, loving somebody who's going through some really awful experiences. And that's the kind of group that I'm really worried about and concerned about, is like, how bad is your life right now because of a traumatic event? How bad is the life of someone that you love or are close to because of a traumatic event? And that's the group that I would say is most at risk for some kind of secondary trauma.
Thank you. And so as we think about COVID, COVID has been a very traumatic experience for many people, especially for our youth. And so, what in particular do you believe makes youth more at risk for certain mental health conditions?
It's a great question, and one that I'm going to struggle a little bit to answer, and one that I'm more than happy to reach out to my child and adolescent colleagues and have them come talk about that piece. I would say that the and again, as part of my caveat about the lens I'm coming through, I got a 13-year-old, an 11-year-old, and an 8-year-old. So they were currently. So when all of this COVID mess was going on, they were there during the public schooling time, then to remote, and then back to public schooling. They got to deal with a dad who is working in the hospital systems for 19 hours a day, kind of coming home grumpy and angry and is just tired and has to change clothes in the back porch and then go through. And I'm working 2 or 3 weekends out of the month. I mean, they had to deal with a parent who wasn't there. And so I bring that up just to say that their experience was one that they weren't necessarily, kids are incredibly resilient and they're incredibly able to manage some of these COVID things. And so they were never a part where I thought they were at physical risk of something awful happening to them. But they generally had to deal with what's that mean in terms of what my experiences are and how I'm interacting with them. What's it mean for my wife and being a teacher? What's it mean for any of us in terms of how we deal with that? And so I think that's been the part that's been really challenging for us to untangle in terms of what that looks like. I don't think that answered your question, and I'm sorry, but that in my mind, that's kind of where I'm coming from and what I think about in terms of what it's been like for a kid.
Yeah. No, I think you did answer the question because your response highlights some difficulties our parents and caregivers may be experiencing themselves about how they are experiencing the pandemic and their own responses to the trauma and secondary trauma, and how they also help their children navigate, but and also for those who may not have children, but they have family members and friends who really are struggling because of what the pandemic has brought to us as a society. So I think that was great because it lets our parents and adults know that not everybody, we don't always have the answers, and that's okay. We can go to our experts who specialize in those areas and be able to ask them for guidance. So what are some signs a person might be experiencing secondary trauma?
Yeah, I think there's and again, I think when I think about how to answer that, the things I really want to emphasize is that part of being a psychiatric group attached to a medical school and attached to a really good hospital system is that we really want to try hard to make sure that we're being very academic, very rigorous, and being very thoughtful. And so the last thing we want to do, and again, the kind of, it's a joke, but it's not a joke. One of the things that we do the most in our clinics and our hospital systems, we stop more medications than we start. We undiagnose people more than we diagnose people. And so our goal is never, and you'll hear me say this over and over again if you're one of my trainees, we're never going to pathologize normal, right? And so if I come home from working, and again, I keep using myself, somebody take, orthopedic surgeon comes home and she's been working for 18 hours straight. She's lost 2 patients to COVID. She's had a miserable time. She comes home, and then because she's been in a COVID scenario during a kind of massive spike, she's got to be on her back porch. She's got to kind of change into pajamas. She can't hug her kids yet. She's got to go through all that kind of stuff. If she's not sleeping well at night because she's seen some horrible things, or if her kids are not sleeping well at night because they've had to deal with what their mom looks like when she comes home and she's so fried and so red, is that a psychiatric diagnosis, or is that just normal, right? I mean, is that just what people go through? And so I think that's what we really struggle with, is how much of this is, a traumatic event that leads to a psychiatric diagnosis versus how much of it is just anybody in this situation is going to go through something exactly as terrifying, right? And it came up to me again in 9/11. We talk with kind of first responders and people who were in New York, and our Rhode Island firefighters went down there and came back. I had a phenomenal friend of mine who's a surgeon, and she was in New York, and when 9/11 happened, she was part of the emergency room team, and they all kind of mobilized to the ED. They waited there expecting mass casualties, and they really didn't happen because of the way the attacks in the buildings felt. And so she was kind of sat there for 12 hours, and then they all kind of went home. And so when she got home, she felt horrible, and she's tearful, and she's crying, and she's not sleeping, and she's having bad appetite. She's got poor attention and concentration, all these kinds of symptoms. But that's just, I think that's normal. And so in my mind, to answer your question, the signs and symptoms people may experiencing this, I'll talk about kind of in diagnostic terms. And so what I think about is, when I talk about that, I think about people who are having intrusive thoughts, which means they're having thoughts of things that, the experiences they've had, the experiences of others have had, that they kind of bombard their brains and they can't get away of. I think of people who are having a hard time sleeping, hard time eating. I'm thinking of people who are having a hard time paying attention or concentrating. I'm thinking of people who startle easily. So whenever something, loud noise, someone says something about COVID, someone said something about 9/11, really gets activated and can't stop dealing with that. I think about feelings of hopefulness, of hopelessness or helplessness. And I think with people who don't feel that they can really continue to live or do this. And so the big caveat that I'll say to that is that, I think a lot of people would have those experiences very normally in a bad situation. And so in my head, when I'm thinking about this, and when you look at all these criteria we use, they use the phrase functional disturbance a lot. Mm-hmm. And so that's the part that I really key on when I'm talking to my patients, when I'm working in the hospital, when I'm working in my psychiatric clinic. is there significant functional distress. So your kid's got a hard time sleeping, they got a crappy appetite, and they're really struggling with attention and concentration in the context of mom coming home late from the OR and not being able to really engage with them. But they're still going to school. Their grades are bad, but not as bad as they could be. They're kind of hanging in there. To me, that's potentially normal experience. And then the king are really focused on their substantial functional problems. So you can't go to school. You can't go to work. You're so miserable that your spouse is looking at leaving you. You're so incredibly upset and angry and frustrated that your kids no longer want to spend time with you. And so they're beginning to have problems. And that's where I really try to focus. And that's where our residents and our team really focuses. And functionally, how are you doing? And if you can't function, all right, that's a thing that we got to be involved in. If you're functioning okay, all right, maybe it's just a normal response to an awful situation, and we can work on that in other ways. But to me, those are the signs that I'm really concerned about. Like what's keeping you from functioning? And the last piece is from a cultural perspective. Again, you're seeing me coming from my lens of, heterosexual Caucasian, married with 3 kids and 2 golden retrievers, and kind of my life expecting, kind of where I am is where I am. But I think the biggest piece for that is, what's considered culturally significant. And so I've got a lot of patients who've come from a very different backgrounds than I have, and their experiences are very different than mine. And so it's hard for me to say, what you're going through is just normal versus what you're going through is really a problem. And so that's where I think talking with families and talking about kind of cultural sensitivity and cultural awareness is huge, because I can talk with families and say, hey, this is what I'm seeing. Is this what people you were like when you were living in Nigeria went through? Like, is this your experience? Is this appropriate? Is this kind of, you use the word normal, but is this kind of how people respond to traumatic events? And having family or others say, no, this isn't what our experience is. This is not what the rest of our family is going through. This is what she's going through. And we really got to focus on that. I think to me, that's the most important thing, is that functional piece. And then from a family or systems or culture perspective, what those issues are specifically. And so that's to me what I think about.
Thank you. I think it's really interesting about the functional piece, the functionality. How do people live their lives and still be able to function? And I love the fact that you brought up the cultural aspect too, because I think different cultures address signs and symptoms very differently. And I was just thinking about, for those who are gifted and talented, they tend to function really well, but still have their mental health conditions that are often overlooked. Because they're functioning at a very high level. I think about my brother, who is so gifted and talented, and we just did not realize he was experiencing depression and anxiety because he functioned real well and hid what he was experiencing as well.
It's so hard, and it's so hard. And again, if I had a great answer to that, I'd be running all of it in terms of psychiatry. And I think part of the reason that we do what we do in an academic setting is we're trying to figure out answers to those questions and how does it work and what do we do? And so I think that's the part that we all struggle with. And so I wish I had a better answer for that.
What are things a person can do to get help and recover from secondary trauma?
Yeah, I think there's a couple of things. And this is, when I think about this, part of the dilemma that we suffer as psychiatrists is that, the last thing we want to do is just create a kind of a treatment plan based on kind of what I've seen. And so the joke we always say is that, the plural of your experience is not data. And so I can't just say that, I saw one person once who had a hard time with Prozac, and so Prozac stinks, and then tell that to all my residents. Now you need research, you need data, you need something that really demonstrates something generally about this. And trauma is really hard because the vast majority of research is on people who have already experienced a traumatic situation. So someone's lost a parent because of cancer. Someone was there when the towers fell. Someone was, in COVID and lost a loved one because of what COVID happened. And we're kind of looking at what happened after that. But it's really difficult to kind of think about what happens before that and thinking about what's there and what's not there. And the reason I bring that up is that I think it's really important that people are being really thoughtful about what they can do before of a traumatic event as opposed to after a traumatic event. So I mean, talk about what it means to get help and what it means to recover. I think it starts with, what are you doing when things start to go south? In some traumatic events, again, 9/11, whatever, you can't predict that or see that. But what can you do in terms of what you're doing now to get yourself prepped for something like when COVID hits, when there's a different travel ban, when something comes up where the state decides they're going to be really emphatic about restrictions or no restrictions, and how does that work? And what are you doing to get yourself prepared or ready for that? Again, it's a silly kind of analogy, but I read a bunch of bad science fiction and a bunch of bad horror novels as part of my way to kind of deal with stress. And one of the things I talked about was these people are really emphatic about what happens in an apocalypse scenario and how do you hunt, how do you build a house, whatever. And the kind of answer from one of the people who had kind of gone through some bad scenarios is, you brush your teeth in the months leading up to it. And I was like, that's a weird thing to say. And their stance is that, having cavities during a time of awful scenarios is bad. And if you brush your teeth and flossed, you wouldn't have cavities. And that's way better than anything you can do in terms of any other kind of preparatory stuff. And so I think about that a lot in terms of what I tell my patients. And I'm like, you need to be kind of setting yourself up for success now. And so what I did badly for myself, and again, this is one of those do what I say, not what I do kind of deals. When I knew that the hospital was beginning to really struggle with that second peak of COVID cases, and what I really struggled with is I kind of threw myself into my work. I'm like, all right, we got doctors out sick, we got people in the hospital that need help. I'm going to start working more hours, doing more things, trying to help out more, being there, and it grinds you down. And so the answer would have been, would the better thing be, all right, I need to take 30 minutes to go run. I need to take 20 minutes to go meditate. I need to be mindful. I need to work on my diet. I've really got to focus on my relationship with my kids and my partner, because I know that in the grand scheme of things, if I don't have that, I got nothing. And so what am I doing to try and create and reinforce those dynamics before things go awful? And so, again, long answer, short question, but what I would say is that what I would really want people to think about is, what are you doing before the trauma to set yourself up for a scenario in which you're doing well after the trauma? And that's not seeing a shrink. It's not taking Prozac. It's not doing anything. It's exercise, which is critical. It's having connections with people. And that means joining a fantasy football team or a knitting circle or a bowling league or whatever. It's having that sense of community and connection. If it's spending time with the loved ones that you really need to be there with you when all of this goes on, it's that. And so I think I would really emphasize you start there. And that's the piece that really sets you up for success afterwards. Again, 9/11 happens and you have zero ability to set that up beforehand, right? I mean, you're watching it on TV and that's awful. And so what I would say after that is that self-care piece doesn't go away. And the thing I always really tell my patients is that if you are, and what I try and tell myself, is that you've got a loved one who's going through something terrifying, you've got somebody who's in the ICU. If you're taking time to go to the movies, you're taking time to go out to eat, you're taking time to do whatever it is to kind of get yourself in a better place, you're not failing your loved ones. You're not failing anything. What you're doing is taking care of yourself, which means that you're better able to deal with their scenarios in the long run, which means that you're helping them, big picture. And so that's what I really want to reiterate, is that self-care is just so incredibly important. And it's not selfish. It's not people failing. It's, if you can't take care of yourself, you can't take care of anybody else. And so that's the plea I keep hammering home over and over again, is that, if you can't manage your own emotions, frustrations, tears, depression, then there's no way you're helping your kids, your family. And so you really got to work on that self-care piece. And that's the part that I think is the most important. And so part of that is, do you talk with NAMI? Do you do groups of NAMI in terms of helping other people support you in terms of what you're going through? Work-life balance is critical. I think exercise is incredibly important. I think the part that I've become most struck by with the literature and the research is that exercise doesn't have to be anything kind of amazing. It doesn't have to be that you're doing, ultra marathons or bench pressing 500 pounds. It's got to be that you're physically active 30 minutes a day during those 30 minutes. And so what are you doing to help you stay active and busy? It means you're engaging in some kind of community. I am completely agnostic as to what that community is. Is it Dungeons and Dragons team? Is it a Warhammer group? Is it a knitting circle? Is it a bowling league? Is it book club? Is it whatever? It's from a kind of a research, what we see is it's completely irrelevant, whether it's AA group or NA group or whatever. It's that sense of community that matters, and virtually nothing else. And so whatever it is that you do, but you get a sense of community from, that's what you focus on. And it's irrelevant what that is, but to me, that's really incredibly important. And then you're seeing a therapist or talking to a shrink is helpful as well, right? So you see a therapist and you talk about what these are if you're really struggling in particular, or if the symptoms, the sleep, appetite, concentration, attention, suicidal thoughts, whatever, if they're becoming really overwhelming, then someone like me or a shrink can really help with medications to some level. But I really think the most important thing by far is taking care of yourself. I don't know, Dr. Farrell, if that seems reasonable or not, or what you would say to that, but that's my mind.
Yeah, it sounds like it's such a simple solution about self-care, but I also think in our society, we've been taught not to be selfish, and people think that sometimes self-care is being selfish, as you mentioned. And so it was great to hear you say it's not being selfish. It really is about nurturing yourself first in order to be able to be with other people and take care of other people as well. And being able to provide yourself permission to take those timeouts, take those moments for yourself to get grounded, and doing the preventative types of strategies, positive coping skills, so that when secondary trauma is experienced, that we already have tools in our belt to be able to rely on, and using our sense of community, as you mentioned, especially for those who rely on their faith communities. I think spiritual, mental, and physical health are all equally important. They're all interlinked together. So yes, I think you did a great job answering the
Yeah,
question.
and again, the analogy everybody used, which is silly, but anyone who's been on a plane, what they always say is put your own oxygen mask on first before you put the oxygen mask on your kid. And that's the analogy that I use as well, is that if you're not breathing, taking care of yourself, doing the right things, you're no good to anybody. And so it's not selfish to take care of yourself. It's selfish to not take care of yourself, because then you burn out and fall apart, and then you don't have any benefit to anybody. Then that's not what you want. And so that's the part that I really want to kind of hammer over and over.
Yeah, that's wonderful. And I know for me, one thing that works is really being able to use some guided imagery, as you talked about work-life balance. So being able to leave work behind and enter into my personal life. So I use a door analogy, some guided imagery in that to really set those boundaries for myself. So I think there are various techniques that people will find helpful for themselves, and also we acknowledge that not all techniques work for everybody. It's about finding what will work best for you. And so what are some things, or what are things that a person can do to protect against future trauma, if that's even possible?
It's a great question, and one that I'm going to really struggle to answer appropriately. I'll give you an example in terms of how we handled it professionally with our group. So for all those who've kind of followed the COVID mess, we've had kind of one big spike that happened a year and a half ago over spring break, and then the second big spike that happened over like 5 or 6 months ago. And one of the things that we did as a group is that kind of after the initial first peak started to come down in the hospital system, everyone was fried. And so what I did is basically walk around to every doc and say, all right, you need to take a week PTO. You got to take PTO, you got to PTO, you be gone. I don't care what you do, go. And the question was, well, but I have to do this, that, or the other. Nah, like if you don't have any support or any kind of structure around what you're doing right now, if you don't feel you've got some space, it's never going to work. And then the expectation was not that people came back from PTO completely centered and fine. And I think that was part of the other thing I really wanted to bang home, was that, nobody kind of takes 2 or 3 days off and comes back completely refreshed, recentered, and everything is perfect now. It's not real life. It's not what it works. But what it means is that you've tried to reinforce those connections with others. And so I think connections with something else is critical. And I don't think it has to be with family. I don't think it has to be with religion. I don't think it has to be with profession. I think it could be anything, but a sense of connection to me is incredibly important. And so that's the thing that I would really emphasize, is that to protect against future trauma, have a connection with something that you feel pleased with, thoughtful for, engaged with, whatever. Again, woodworking club, AA group, bowling league, whatever, really is fundamentally irrelevant what it is. What matters is that there's a sense of connection. And so that's the part that's there. I do think, and again, this is one of those do what I say, not what I do kind of things. Again, knowing that I married a marathon runner, and my own experience is eating barbecue and laying around the backyard, what I would say is that the most important thing is, I think having some physical outlet is incredibly helpful. And again, I think the part that I keep banging home to my patients is 30 minutes a day of some cardiovascular activity. And that can be boxing, it can be kickboxing, it can be, walking a dog, it can be whatever, but that sustained elevated heart rate for 30 minutes has a lot of data to support that it's incredibly helpful. And so I would really push that piece as being something I would be really thoughtful about. I think being really mindful of cynicism is really helpful. And again, I'm a bad person to say that, because I kind of, especially first responders, and again, I'm a shrink, so take it off his word, but a lot of first responders really focus on kind of dark humor or black humor, or kind of think about things that are more kind of morbid than not. But I think you can really get into a trap of kind of falling into a kind of a sinking cynicism. And there's a lot of things that are awesome. And we're in a fantastic city. And again, I know it's weird, but there's a lot of stuff going on right now, but we're in a fantastic city. We're doing a lot better than a lot of other people are. And I think you want to be Pollyanna and just kind of gloss over a lot of things that are really challenging right now. But there's a ton of good stuff that's happening. And so focusing on that, I don't think is necessarily inappropriate. I think it really helps pull people out of what that thought is. And then last thing I said is that something we talked about connection sense, but I think the other piece that I talk about is something that you feel is generative or helpful, or something that is really critical for you in terms of what you do. And so I think about what I tell my kids. And so what we've always told our children, kind of 13 and down, is that you got to do some physical activity, you got to do some artistic activity. I don't care what you do. Like once a week, you got to do something athletic. Once a week, you got to do something artistic. What that is, I don't care. If you're writing, if you're playing piano, if you're playing drums, if you're doing guitar, if you're doing poetry, if you're doing clay, like whatever. If all you're doing is sitting at a table and drawing for an hour, don't care. But you need something that you're passionate about, or something that you want to actually engage in that's relevant to you. Again, playing video games, if it's cooking, if it's pick it, and I don't care what it is, but something that you feel is kind of really something that rejuvenates you or helps you build back your energy, whatever that is. I think that's the part that I think is really critical. And again, you want to fall into it. So you're playing video games for 22 hours a day. That's not okay. That's a functional distress thing that we talked about, and something we got to worry about. But if it's something that you find a connection with, something you enjoy, I think that's where it is.
So it really seems like it's about finding some balance. Not overdoing, not underdoing, finding balance, and also finding things that are really meaningful to you, that you find joy and value, and really keeps you uplifted. Is what I'm hearing the message being conveyed to us.
I know we're running short on time, so I'm really sorry. But I think the part that I want to kind of say about that is that, I think sometimes people get caught on that trap where they think it's got to be, I'm at church, or I'm, sculpting out of marble, or I'm, whatever. And I've got to have a family, I've got to have a spouse, I've got to have kids, I've got to have all that to find me. I don't think that's it. I mean, if you met your Halo objectives and got, kind of where you wanted to go in video games, I don't think that's necessarily problematic. I think it's less of kind of the big picture stuff. And what I want people to really thoughtful of is it doesn't really matter how, again, it doesn't have to be church, it doesn't have to be, spouse with kids, it doesn't have to be, working as a, librarian who's helping to cure. It doesn't have to be any of that. It's something that you find some meaning in, or something you find some joy in. And that's it. And so I find that's the key thing to focus on, as opposed to what the specifics are, what the big picture is. And what's joy for someone may not be joy for anybody else.
Right.
It doesn't matter. It really doesn't, as long as there's something you feel connected to and attached to.
Thank you. A question actually popped up, and this actually might go with how can a family, and I know we only have a few more minutes, how can a
That's
family
right.
or friend help someone who's experiencing secondary trauma? But the question that was submitted was, what do you do for those who may lack a support system or may even be homeless, and so they don't have the things that you were talking about
Yeah,
available?
and I think what I would say in kind of a combination for that question, how can family or friends help versus someone who's experiencing, kind of being unhoused? I think the part that I really emphasize is that, talking about how bad they're feeling is rarely necessarily helpful. And so it wouldn't be like, yeah, you look really depressed, you look terrible, you've got psychotic symptoms, you got all that kind of stuff. Not really useful. What's useful is like, what are you doing to help yourself right now? And so it means, again, not focusing on what their experience is and not focusing on how bad they're doing and not focusing on the traumatic events that happened to them. So, you going up to someone, a nurse, and saying, man, yeah, you worked 12 hours in an ED and you saw a lot of people die from COVID. That's got to be pretty bad, huh? Like, what was the worst one you saw? That's not helpful. What's helpful is how you build those supports up. And so what I would say is that when I'm talking to my family members, when I'm talking to my, people that I meet when I'm driving and they kind of come up to wash my windshield and we're talking about this, it's really not about kind of what their experiences are. It's more about what are you doing to get some support and structure around you here. And so that's the part that I really focus on. So, hey, you're unhoused and you got a really hard time right now, especially after kind of all the legislative issues that have come up. You had a really hard time. So what are you doing to take care of yourself, to help yourself? Like, do you need financial resources to go to an Anytime Fitness and get a shower and go work out for a bit? Do you need like a space to get some food? Do you need some time for some kind of decompression and a chance to sit and talk to other people? Like, what part of that is what you want to do, and how do I help you with that? And to me, that's what I do to help my family. It's what I do to help my friends. It's what again, as you might imagine, kind of given what I do for a living, I get a lot of people who ask me for these kinds of things. And that's what I really focus on. I'm a little bit less worried about trying to make them talk about what their experience is. And I'm a lot more concerned about making sure they've talked about what resources they have to help them. And it doesn't have to be, an apartment and $2,000 a year. It's got to be something they feel a connection with. And that's the part that I feel really emphatic about.
Wonderful, thank you. I know our time is actually up. Oh, that was the question and answer. So if we just have a few more minutes, let me see. Oh, and the person actually said you answered the question. So yeah, which is
Nice.
wonderful.
I'm
Yeah.
pleased that I was able to manage that. So
Yeah,
that's good.
and it's 8:32, so I just want to make sure that there's no final thoughts that you would like to share with us before I close for the evening.
No, and again, I'm sorry for taking longer than I should have, and I apologize for that. I know it's a really hard time of year and a really hard time for people to engage with this, but I'm thrilled that people were able to hopefully get some benefit from this. Um, we're all in this together,
Yes,
right? I
yes,
mean,
we are.
it's been really challenging for everybody over this time, and if we're not looking out for each other, we're not going to be able to make it work. And so anything we can do across any of the different divides that we've got is something that's really important to make sure that we're helping out any way we can. And so I firmly feel that and want to make sure that we're trying to support that. And I say we, I mean anybody here in Austin, whatever healthcare system, whatever medical, whatever. We're here to make this work, and we're here to work with y'all to help it happen. And that's what I really want to make sure we do.
Yes, thank you. I appreciate your time this evening, Dr. McRoberts, and everybody's time for taking an hour of their evening to sit in and listen to the wonderful information. I really think what I got out of this was just you normalizing the secondary or vicarious trauma and really being able to let us know that it happens. And there's nothing that we should be ashamed about, but there are things that we can do to address and really be able to take care of ourselves, have that sense of connection with others, engage in activities that are meaningful and joyful for us, and that it looks very different across individuals. And so there's no right or wrong way of experiencing and addressing trauma that we may experience. Someone said, thank you so much. Took a lot of notes from this presentation. And I just want to say good evening to everybody, and just a reminder, we have 2 more My Matters coming up in December, and then 2 more in January. And this presentation will be available on our website at some point. So if you would like to come back and re-listen and or just share, it's really important. You can be helpful to others by sharing the resources that are available to